Okay, this is our last presentation in the Respiratory Care Symposium session on inhaled gases. Back with us is Dr. Bob Kacmarek, who's a professor of anesthesiology at Harvard Medical School and director of respiratory therapy services at Mass General Hospital in Boston, Massachusetts. Thank you.
Thank you. So let me begin with my same disclosures as I had before. I'm a consultant for Covidien Newport. I've received research grants from Covidien and Hollister, and I've received honoraria from McKay for lecturing. So I've been asked to talk about inhaled vasodilators, primarily inhaled pulmonary vasodilators. And I'm probably not the right person to do this presentation. Mark, who's in the audience, is the one who should be standing up here and doing this. I'm using some of the material from various papers that he's written, and as you're well aware, the reason why we have focused on the use of inhaled versus systemic bronchodilators is because the drugs we use, nitric oxide being the prototypic drug, is that because of the rapid conversion of the drug to an inactive state, we don't have any effect outside the lung. So we have all the local effects that we want from the drug, but we don't have the systemic effects that we see when we administer a vasodilator to patients systemically. So we get improvement in shunt, we get improvement in pulmonary blood flow, but we do not see the dilatation in the systemic circulation, which happens when we give a systemic bronchodilator, where overall the effects tend to be the exact opposite. Because once you have a systemic effect, you get vasodilatation in those areas where we have shunt, which increases the percent shunt, drops the FiO2, and of course creates systemic hypotension. So it appears that giving the drug by aerosol is the most appropriate because the drug will only have an effect where it has the ability to contact blood vessels that are well perfused. So if I've got an area of shunting where the nitric oxide can't make it to the vasculature, it is not going to dilate that vasculature. It will only dilate the vasculature that's well ventilated. So I see a nice improvement not only in the pulmonary vascular resistance, but the thing that made everybody stand at attention in regards to this associated with ARDS patients is we got a very good response from an oxygenation perspective when we delivered this drug, this simple drug, via the respiratory system. And as we look at nitric oxide and prostacyclin, the primary other inhaled drug that we're using by a number of various different compounds and names, the thing that we're starting to see, and as I review the literature, what is becoming more and more apparent to me is that patients who have very severe and unresponsive pulmonary hypertension, we may see the use of combination drugs. In most circumstances, either nitric oxide, as you'll see from the literature, or prostacyclin via two different mechanisms, nitric oxide here, prostacyclin here, eventually both come down and cause vascular relaxation. But in the patient with persistent and severe pulmonary hypertension, one by itself may not have a significant effect without causing side effects, but using combination drugs that approach vascular relaxation from alternate mechanisms seems to be the way things are going, at least in the cardiology literature, which at least in our institution is where we're using the vast majority of these types of agents. Not saying we don't use them in neonates, as you know, where nitric oxide has been approved by the FDA. Yes, we do, but really much less today as a result of better care than we did previously. We do use them in patients who have ARDS, although as I'll show you in a second, there is nothing to support using them in ARDS. But where we are seeing a boom in the use is managing patients with pulmonary hypertension, either acutely in the intra-operative or post-operative cardiac surgical arena, or patients who have persistent primary pulmonary hypertension for whatever reason, and it is difficult to get them under control, particularly during an acute exacerbation. Well, Mark and Dean did this meta-analysis in 2010 in respiratory care. And I think it points to the fact why it is probably unnecessary, other than from a cosmetic perspective, to use nitric oxide in patients with the adult respiratory distress syndrome. As you'll noted, when they looked at all these studies looking at nitric oxide usage in ARDS and the response of oxygenation or improvement in oxygenation, clearly there is a benefit with nitric oxide. However, when you look at mortality, no significant difference, but clearly the movement is more on the control side with better overall outcome. So we have a drug that increases the PO2, but it tends to not have an effect on outcome in ARDS. And quite honestly, as I go and review the rest of the literature that deals with the use of either nitric oxide or prostacyclin and its derivatives in the management of pulmonary hypertension, there are no other outcome studies. The studies are short-term physiologic, I shouldn't say short-term or long-term physiologic response, but the outcome of interest, that is the change in pulmonary hypertension, there is no study that looks at length of time in the ICU, speed of recovery from surgery, patients' overall survival. They've been simply looking at the physiologic response associated with changing the pulmonary hypertension. Do I expect in many of the cardiac surgical patients that had an impact on mortality? Absolutely. Absolutely, I believe so. But there isn't in the data that's currently available, and this is why all of us tend to try to avoid the use of nitric oxide in ARDS. That, coupled with the exorbitant cost of nitric oxide, as you're well aware if you're using it in your institution, the cost is excessive and it continues to go up, and we have no data in ARDS that would imply any benefit from an outcome perspective. So every one of us are looking for alternatives to the use of nitric oxide. And this is just from the biggest study that Dillinger was the first author on, that was funded by the company, and shows what happens and what we see all the time. You start nitric oxide in ARDS, particularly if you don't manage it to the lowest dose that sustains the benefit, over a day or two, you lose the effect. And you get a bump initially in the oxygenation status, it goes back, and patients are equivalent from an oxygenation perspective to controls very rapidly. So this is the first study in ARDS patients that I'm aware of that they compared nitric oxide to prostacyclin. 16 patients with ARDS, short-term random application, both titrated to produce the maximum effect. And as you can see, the doses that were used pretty consistent with some of the doses that we use now at the bedside. And it's pretty hard to argue the big difference here. As a matter of fact, I would have to say from a pulmonary vascular resistance perspective that the prostacyclin did a better job than the nitric oxide did. From an oxygenation perspective, shunt fraction, PF ratio change, are approximately equivalent. A little bit more change in the this is the mean pulmonary artery pressure. In this study, there is no spillover effect. One of the problems with the use of prostacyclin is if you're using too high a dose, you do not have the drug totally metabolized in the lung, and you can get systemic hypotension. Every time we've seen that, we've been able to manage those patients by decreasing the dose to a lower acceptable dose that still produce the desired overall response. This was a German group, Putinson, published 10 patients ARDS receiving nitric oxide, prostacyclin by aerosol or IV. And as we look at their data, I realize this is a little difficult to see. I apologize for this. This is baseline. This is nitric oxide. This is the administration of prostacyclin by aerosol. This is the administration of prostacyclin IV. And the take-home message on this graphic is that as I look at all the variables that are evaluating pulmonary vascular resistance, mean pulmonary artery pressure, no difference between the three approaches except when I start looking at the systemic effect. Systemic vascular resistance, systemic pressures, the IV administration of prostacyclin had a negative effect from our perspective, that it did decrease pressures. But nitric oxide by aerosol or prostacyclin by aerosol, essentially equivalent effects. And as I look here at oxygenation and shunt fraction, no difference. Here is nitric oxide, here is prostacyclin. From an oxygenation perspective, equivalent. No difference in the overall response from this series of patients. If we look at patients without ARDS, there is an increasing amount of literature that's being published, as I said before, particularly from the cardiovascular surgeons or cardiac surgeons. This is the earliest one that really focused in on the effect of a number of different drugs and combinations, but 30 patients with severe pulmonary hypertension randomly received sildenafil at 2 different doses, sildenafil plus inhaled iloprost, a form of prostacyclin, and then sildenafil plus iloprost at different concentrations. All of this was administered after the patient first received nitric oxide and then received iloprost at a low dose. All combinations resulted in a decrease in the mean pulmonary artery pressure. What am I doing wrong? And as we look here, the results from a change in mean pulmonary artery pressure, a change in pulmonary vascular resistance over systemic vascular resistance percentage, and change in cardiac output. Combinations of the drugs seem to be beneficial. There's no question that depending upon the patient and depending upon the severity and the longevity of the pulmonary hypertension that they're presenting with, you may be asked to give multiple drugs, both by inhalation. We have given nitric oxide by inhalation along with prostacyclin, and they've done sildenafil or other systemic administrations of drugs to try to maximize the pulmonary vasodilatory effect of the drug. And I anticipate, based on the literature, that is going to be a trend in how patients are managed. They isolated a few specifics, but as you'll notice here, if we look at the change in pulmonary vascular resistance, the sildenafil followed by the iloprost seem to have the greatest overall impact on pulmonary vascular resistance, at least in this series of patients with persistent long-term pulmonary hypertension that they evaluated. Cardiac surgical patients, randomized comparison of nitric oxide, prostacyclin, and sodium nitroprusside after mitral valve replacement, approximately 20 patients in each of the 3 groupings. As you'd expect, the prostacyclin and nitric oxide significantly decreased the mean arterial pressure, the pulmonary vascular resistance, and the transpulmonary gradient, as well as increasing cardiac output. Sodium nitroprusside had the same effect, except it had to be interrupted in 62 patients because of systemic hypotension. And we tend not to use it in this particular scenario. And if you look at the actual numbers, here's the problem. These patients dropped their systemic blood pressure as a result of sodium nitroprusside. The other 2 groups, there were minimal changes, and all 3 had equivalent changes in the pulmonary mean pulmonary artery pressure, as well as pulmonary vascular resistance and the change in transthoracic gradient. I apologize, I must be hitting the go forward or backward button. More recent study, 46 patients who had persistent pulmonary hypertension, preoperatively, intraoperatively, and postoperatively. Patients were randomized to receive iloprost or nitric oxide. Both reduced mean pulmonary artery pressure, pulmonary vascular resistance, and increased overall cardiac output. Iloprost caused a significantly greater reduction in pulmonary vascular resistance and mean pulmonary artery pressure, and a larger increase in cardiac output, at least in this population of patients. Another one, randomized comparison of nitric oxide with prostacyclin in the form of Floland, 32 heart and lung transplant recipients. No difference in all measured variables. After 6 hours of treatments, the patients were crossed over, and again, no difference. And if you see there the graphic presentation, no difference in the responses as they switched over from nitric oxide to prostacyclin. And every variable that they evaluated, their assumption was there was equal overall response. No benefit. I could not find a single study where it showed a benefit to nitric oxide over the use of prostacyclin to manage patients who were presenting with pulmonary hypertension, particularly in association with cardiac surgical related issues. More recent article, 7 patients with right ventricular dysfunction following an RVAD insertion maintained on nitric oxide of 10 ppm and 10 micrograms of inhaled iloprost periodically, significant reductions in all variables as these patients were maintained over the process of the study. And as you will see, when they added the iloprost to the nitric oxide over time, improvements seemed to increase, both in relationship to, this is the mean arterial pressure over, mean pulmonary artery pressure over mean arterial pressure ratio, as well as the mean pulmonary vascular resistance over the systemic vascular resistance ratio. 20 cardiac surgical patients with out of proportion pulmonary hypertension, significant pulmonary hypertension, both pre-op and post-op in these patients. Randomized to receive Group A. The way they set this up was to have nitric oxide first, followed by sildenafil, and then a second group, sildenafil followed by nitric oxide. Group A reduced mean pulmonary artery pressure and mean pulmonary vascular resistance. The same thing occurred in Group B, but these patients also had a problem with a decrease in systemic vascular resistance, but showed a higher improvement in PO2. I'm not sure exactly, why that was the case, but clearly their data would indicate that. So use of sildenafil first, followed by nitric oxide, had a greater systemic effect than the reverse, at least in this population, of patients that they followed. As you look at their graphic representations, as we get over here to mean arterial pressure, here is sildenafil first and then nitric. Here is nitric first, then the combination. This here is the systemic vascular resistance index, and you can see it's a little bit lower when sildenafil was given first, followed by the combination with nitric oxide as a secondary drug to be given. This one is still in press in the Journal of Cardiothoracic and Vascular Anesthesia. 8 patients with valvular disease on ECMO with pulmonary hypertension and prolonged right heart failure. 10 ppm nitric oxide plus iloprost given every 2 hours. Decrease in pulmonary vascular resistance, decrease in mean pulmonary artery pressure, increased cardiac output, increase in mixed venous O2 saturation. With every dose of iloprost, it seemed to improve the function of these patients. So as you looked again at their data over time, this is in hours, 1 hour up to 5 hours. So when you look at these last few articles in these patients with severe hypertension, it's easy to understand why we're getting orders on occasion from the cardiac surgeons to put drugs together. When they get a response, but they don't see the response at the therapeutic level that they would like to see with a given patient, they're adding other medications onto it in order to enhance that response, which is clearly supported in the literature. Small numbers, again, no outcome data, but from a physiologic response, clearly that physiologic response is there. So we've negotiated, as I'm sure many of you have, with the cardiac surgeons, and have made a concerted effort to try to decrease the use of nitric oxide. We begin nitric oxide in the OR, we begin it in the cath lab, we begin it in the ICU, etc. We prefer beginning with prostacyclin, but that doesn't always happen. And when nitric oxide ends up to be the primary drug that's administered, we've established a routine of attempting prostacyclin to see whether or not it can replace nitric oxide with an equivalent response. And we found that under most circumstances, it does. Clearly, there are some patients who we cannot transition to prostacyclin, and there are some patients that do better with prostacyclin than they do with nitric oxide. But we try to get the physician, as soon as the patient is stabilized, to allow us to add prostacyclin to the nitric oxide, allow for stabilization over a period of time, usually 1 hour, and then slowly decrease the nitric oxide and 50% decreases over the next hour, and then reevaluate the patient response, getting good data at each point of transition. And if after we've discontinued the nitric oxide, the patient's hemodynamic status is equivalent to what it was prior to discontinuing it, then we leave them on prostacyclin. If the patient does show a dramatic change for the negative in their hemodynamic profile as we're dropping nitric oxide, or at the end, we go back and reestablish nitric oxide. And we found that this approach has worked in a large number of patients, although again, there are patients who will have a preference, from a response perspective to one or the other of these drugs. So in conclusion, nitric oxide and prostacyclin work on average equally well in reducing pulmonary hemodynamics and improving oxygenation. I cannot find any data, and I was a little surprised, to be quite honest with you. I thought that I'd find articles that said yes prostacyclin and other articles that said yes nitric oxide, but I could not find any, at least that I reviewed. I mean, there may be people in the audience who know other ones, but I could not find literature that said one or the other should be preferred in any of these circumstances, whether you're talking about ARDS or you're talking about pulmonary hypertension chronically or acutely. The literature does not seem to indicate a difference. The only caveat to that would be the greater potential for systemic hypotension with prostacyclin than there is with nitric oxide. However, in some patients, as I said, nitric oxide works better, others prostacyclin works better. I would expect that in those persistent and severe patients with pulmonary hypertension, we'll see more and more combination drugs, as was indicated here. I think this is a trend, and we can expect that to be occurring. No data indicating outcome is improved, though. There is, unless somebody knows of a study that I'm not aware of, other than a physiologic response, I could not find anything that implied that there was a change in any normal outcome that we would consider, appropriate for a critically ill intensive care patient. Thank you.